Shock. Shock. Shock is defined as a state of cellular and tissue hypoxia with either reduced oxygen delivery or poor oxygen utilization or increased oxygen consumption with circulatory failure, collapse, and poor perfusion. Normal aerobic metabolism is not maintained due to hypoperfusion. Shock is meant by inadequate perfusion to maintain normal organ function. It may be initially reversible but becomes irreversible eventually if not treated, leading multi-organ failure and death. Shock can be hypovolemic, 16%, cardiogenic, 16%, distributive, septic, 62%, neurogenic, anaphylactic, 4%, acute adrenal insufficiency, or obstructive, 2%, or endocrine, hypothyroidism, thyrotoxic crisis, adrenal insufficiency. At cellular level, hypoxia causes change of normal aerobic to anaerobic metabolism causing lactic acidosis. Intracellular potassium is released into circulation. Lysosomes from cells get released into blood causing cell lysis. Hypoxia and acidosis through complements release free oxygen radicals and cytokines which damage capillary endothelium. Eventually cardiovascular, respiratory, renal, endocrine and GIT will be affected, presenting as systemic features. Causes of shock. 1. Hypovolemic shock, due to reduction in total blood volume. It may be due to A, B, C, D. Hemorrhage. External from wounds, open fractures. Internal from injury to spleen, liver, mesentery or pelvis, severe burns, which results in loss of plasma, peritonitis, intestinal obstruction, vomiting and diarrhea of any cause. 2. Cardiac causes. A. Acute myocardial infarction, acute carditis. B. Acute pulmonary embolism, wherein embolus blocks the pulmonary artery at bifurcation of one of the major branches. C. Drug-induced. D. Tauchemia of any causes. A. Cardiac surgical conditions like valvular diseases, congenital heart diseases. F. Cardiac compression causes. I. Cardiac tamponade due to collection of blood, pus, fluid in the pericardial space which prevents the heart to expand, leading to shock. E. Trauma to heart. Three. Septic shock is due to bacterial infections which release toxins, leading to shock. Neurogenic shock, due to sudden anxious or painful stimuli causing severe splanchnic vessel vasodilatation. Here, patient either goes for cardiac arrest and dies or recovers fully spontaneously. Spinal cord injury, anesthesia can cause neurogenic shock. 5. Anaphylactic shock is due to type 1 hypersensitivity reaction. 6. Respiratory causes. A. Atelectasis, collapse of lung. B. C. Thoracic injuries, tension, pneumothorax. D. Anesthetic complications. 7. Other causes. A. Acute adrenal insufficiency, Addison's disease. B. Myxedema. Pathophysiology of shock. Any cause of shock, down pointing arrow. Low cardiac output, down pointing arrow. Vasoconstriction occurs as a compensation to perfuse vital organs like brain, heart, kidneys, liver, down pointing arrow. Because of vasoconstriction and tachycardia, down pointing arrow. Dynamic circulation increases, down pointing arrow. Tachypnea occurs to increase the oxygen saturation, down pointing arrow. Peripheral veins, capacitance vessels, constrict, diverting blood from splanchnic system towards essential vital organs, down pointing arrow. Decreased renal blood flow reduces the GFR and thereby the urine output, down pointing arrow. Renin-angiotensin mechanism gets activated, causing further vasoconstriction and aldosterone release, down pointing arrow. Causes salt and water retention. UD has released down pointing arrow. Further concentration of urine occurs. When shock persists, cardiac output falls, further down pointing arrow. Hypotension and tachycardia occurs, leading to poor perfusion of coronaries, down pointing arrow. Hypoxia, metabolic acidosis, down pointing arrow. Release of cardiac depressants, down pointing arrow. Cardiac pump failure. Hypoxia, down pointing arrow. Anaerobic metabolism, down pointing arrow. Lactic acidosis, down pointing arrow. Cell wall damage, down pointing arrow. Sodium and calcium enter the cell, down pointing arrow. Potassium leaks out of the cell, down pointing arrow. Causes hyperkalemia, hyponatremia and hypocalcemia, down pointing arrow. Intracellular lysosomes break down, releasing powerful enzymes which destroy own cell, down pointing arrow. Sick cell syndrome. Platelets are activated, forming small clots in many places, down pointing arrow. Disseminated intravascular coagulation, DIC, consumption coagulopathy, down pointing arrow. Further bleeding. Stages of shock. Factors like infection, trauma, burns, hemorrhage, hypovolemia, down pointing arrow. Hypoxia and its effects. Down pointing arrow. SIRS, systemic inflammatory response syndrome, is due to vasodilatation, increased endothelial permeability, thrombosis, leukocyte migration and activation. Down pointing arrow. All these lead to altered cytokines level, abnormal nitric oxide synthesis, abnormal arachidonic acid metabolism, neutrophil activation. Free radical production, altered complement activation, failure to have a localization of inflammation. It is severe type of reversible shock. Down pointing arrow, which will lead to established microvascular occlusion, cellular dysfunction, sick cell syndrome, DIC and pump failure. Down pointing arrow, MODS, multi-organ dysfunction syndrome, irreversible shock of lungs, kidneys, liver, clotting system and brain. B stages of shock. XX stage of hypoperfusion and hypoxia. Aerobic metabolism changes to anaerobic, leading to lactic acidosis, metabolic acidosis. XX stage of compensatory shock. It is neuroendocrine response to maintain the perfusion of vital organs like brain, lungs and heart. Noradrenaline, renin-angiotensin and antidiuretic hormone, UD, gets activated, causing vasoconstriction of organs like gastrointestinal, kidney to divert the blood to heart, lungs and brain. XX stage of decompensatory, progressive, shock. Here compensatory mechanism fails, cell perfusion decreases, causing raised intracellular sodium but low intracellular potassium. Microcirculation fails, beginning the failure of kidneys, liver and lungs. XX stage of irreversible, refractory, shock. Here cellular ATP metabolism is lost completely, leading into MODS and MOF, multi-organ failure. Note: distributive shock is one in which there is vasodilatation, decreased vascular resistance, hypotension, altered microvascular perfusion with arteriovenous shunting, altered cellular oxygen metabolism. It is seen in septic shock, spinal trauma, adrenal crisis and anaphylaxis. Obstructive shock occurs due to mechanical impediment of circulation due to pulmonary embolism, tension pneumothorax or cardiac tamponade, aortic stenosis. Effects of shock. Heart. Low perfusion, right pointing arrow. Low venous return, right pointing arrow. Decreased cardiac output, right pointing arrow. Hypotension, right pointing arrow. Tachycardia. Persistent shock causes hypoxia and release of myocardial depressants, leading to further cardiac damage. Lung. Interstitial edema, right pointing arrow. Decreased gaseous exchange, right pointing arrow. Pulmonary arteriovenous shunting, right pointing arrow. Tachypnea, right pointing arrow. Adult. Acute respiratory distress syndrome, ARDS, and pulmonary edema. Metabolic. Shock leads to hypoxia, which activates anaerobic metabolism, leading to lactic acidosis. Antidiuretic hormone, UD, is released, which increases the reabsorption of water from renal tubules. Other hormones released are ACTH, prostaglandins, histamine, bradykinin, and serotonin to compensate the effects of shock to increase the perfusion of vital organs like heart, brain and lungs. Cellular changes occur in persistent shock due to release of lysosomal enzymes, which alters the cell membrane permeability causing cell death, sick cell syndrome. Sympathetic overactivity alters the microcirculation leading to capillary dysfunction. Brain perfusion. When decreases, the patient becomes drowsy. Brain is the last organ to get underperfused in shock. Kidneys. GFR decreases and tubular reabsorption of salt and water increases for compensatory response. But in severe cases, tubular necrosis sets in, leading into irreversible damage. Blood. Alteration in cellular components including platelets leads to disseminated intravascular coagulation, DIC. It causes bleeding from all organs. Gastrointestinal tract. Mucosal ischemia develops causing bleeding from GIT with hematemesis and melena. It is aggravated by DIC. Hepatic ischemia leads into increased enzyme levels. Types of shock. 1. Vasovagal shock. It is sudden dilatation of peripheral and splanchnic vessels causing reduced cardiac output and shock. Often it may be life-threatening due to hypoxia. 2. Neurogenic shock. It is usually due to spinal cord injury, which causes dilatation of splanchnic vessels. 3/4. This type can safely be treated with vasoconstrictor drugs to bring up the blood pressure. There will be bradycardia, hypotension, arrhythmias, and decreased cardiac output. Blood pressure control, oxygen delivery, maintenance of hemodynamics, airway, fluid therapy, intravenous methylprednisolone therapy should be done. Dopamine and or phenylephrine, alpha agonist, can be used. 3. Hypovolemic shock hemorrhage, may be due to injury to the liver, spleen, bone fractures, hemothorax, vascular injury, severe bleeding on table during surgeries of thyroid, liver, portal vein or major vessels. Vomiting, diarrhea due to any cause. Burns. B. Types of hypovolemia. A. Covered compensated hypovolemia, mild less than 15%, when blood volume is reduced by 10 to 15%, there will not be significant change in heart rate, cardiac output and splanchnic blood compensates for the same. B. Overt compensated hypovolemia, moderate 15 to 40%, here patient has cold periphery, tachycardia, a wide arterial pressure, tachypnea, confusion, hyponatremia, metabolic acidosis, but systolic pressure is well maintained but postural hypotension. C. Decompensated hypovolemia, severe greater than 40%, here all features of hypovolemia are present like hypotension, tachycardia, sweating, tachypnea, oliguria, drowsiness, eventually features of SIRS is seen and often if not treated on time leads to MODS, i.e. irreversible shock. Four. Cardiogenic shock. Cardiogenic shock is defined as circulatory failure causing diminished forward flow leading into tissue hypoxia in the setting of adequate intravascular volume with systolic blood pressure less than 90 mm of mercury for 30 minutes, cardiac index less than 2.2 L per minute per square meter, raised PCWP, pulmonary capillary wedge pressure greater than 15 mm of mercury. It is commonly seen in acute ME with a mortality greater than 50%. 3/4. Cardiogenic shock develops within 24 hours of ME. It occurs when 50% of left ventricular wall is damaged by infarction. 3/4. It leads to pulmonary edema and severe hypoxia. Ischemic necrosis of left ventricular wall causes failure of pump, thereby decreasing stroke volume. Diagnosis is established by ECG, echocardiography, arterial blood gas analysis, cardiac enzymes, PCWP and electrolyte estimation. Hypokalemia and hypomagnesemia are common, are the essential investigations. Management: proper oxygenation with intubation, ventilator support, cardioversion, pacing, antiarrhythmic drugs, correction of electrolytes, avoiding fluid overload, prevention of pulmonary edema is immediate measures. Dobutamine, beta-1 receptor agonist, is used to raise cardiac output provided there is adequate preload and intravascular volume. It is peripheral vasodilator and reduces BP. Dopamine is preferred in patients with hypotension, but it may increase peripheral resistance and heart rate worsening cardiac ischemia. Often both dopamine and dobutamine combination may be required. Careful judicial use of epinephrine, norepinephrine, phosphodiesterase inhibitors, amrinone, milrinone, are often needed. Anticoagulants and aspirin are given. Thrombolytics can be used. B blockers, nitrates, nitroglycerine causes coronary arterial dilatation. ACE inhibitors are also used. Intra-aortic balloon pump, IABP, may need to be introduced transfemorally as a mechanical circulatory support to raise cardiac output and coronary blood flow. Relief of pain, preserving of remaining myocardium and its function, maintaining adequate preload, oxygenation, minimizing sympathetic stimulation, correction of electrolytes should be the priorities. Percutaneous transluminal coronary angioplasty, PTCA, and coronary artery bypass graft, CABG, are the final choices. 5. Cardiac compression shock. It is probably due to pericardial tamponade of any cause or kinking of great vessels. Massive pulmonary embolism, tension pneumothorax, air embolism causes obstructive shock with reduced preload to heart. Acute massive pulmonary embolism from a thrombus or an air embolism, 50 milliliters of air, obstructing more than 50% of pulmonary vasculature leads to severe shock and sudden death. Tachycardia, hypotension, pulmonary edema, raised JVP, gallop rhythm are the features. Six. Septic shock. Septic shock may be due to gram-positive organisms, gram-negative organisms, fungi, viruses or protozoal origin. Gram-negative septicemia per gram-negative septic shock is called as endotoxic shock. It occurs due to gram-negative bacterial infections, commonly seen in strangulated intestines, peritonitis, gastrointestinal fistulas, biliary and urinary infections, pancreatitis, major surgical wounds, diabetic wounds and crush injuries. Gram-positive septic shock, due to exotoxin by gram-plus-way bacteremia like Clostridium tetani, Welchii, Staphylococci, Streptococci pneumococci. Fluid loss, hypotension is common, with normal cardiac output. Gram-negative septic shock. Gram-negative bacteria cause endotoxemia and its effects. Urinary, gastrointestinal, biliary and respiratory foci are common. Pathophysiology of septic shock. Toxins, endotoxins from organisms like E. coli, Klebsiella, Pseudomonas, and Proteus down-pointing arrow. Inflammation, cellular activation of macrophages, neutrophils, monocytes down-pointing arrow. Release of cytokines, free radicals down-pointing arrow. Chemotaxis of cells, endothelial injury, altered coagulation cascade, SIRS down-pointing arrow. Reversible hyperdynamic warm stage of septic shock with fever, tachycardia, tachypnea down-pointing arrow. Severe circulatory failure with MODS, failure of lungs, kidneys, liver, heart, with dick down-pointing arrow. Hyperdynamic, irreversible cold stage of septic shock. Septic shock is typically a vasodilatory shock wherein there is peripheral vasodilatation causing hypotension which is resistant to vasopressors. This is due to toxin-induced release of isoform of nitric oxide synthetase from the vessel wall which causes sustained prolonged release of high levels of nitric oxide. Magnitude of infection is quantified as 1. Mild sepsis which shows fever, tachycardia, leukocytosis. 2. Severe sepsis which shows low tissue perfusion with organ dysfunction, lactic acidosis, dysfunction of liver, kidney, lungs. 3. Septic shock with systemic hypotension, BP less than 90 mm of mercury in spite of adequate fluid therapy, severe organ dysfunction. TN, acute lung, kidney, liver injury, maldistribution of blood flow, shunting in microcirculation. If despite adequate resuscitation, a patient requires vasopressors to maintain MAP is greater than or equal to 65 mm of mercury and serum lactate level is greater than 2 millimoles L. Note: sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection identified by the presence of 2 or more SOFA points, SCOs, sequential, sepsis-related organ failure assessment. Quick SOFA, Q-SOFA, SCO is also used. Low blood pressure less than 100 mm Hg, increased respiratory rate greater than 22 per minute, altered mentation, GCS less than 13. Refer Chapter 1D, Infectious Diseases, Septicemia. Mean arterial pressure, MAP, is an average blood pressure during single phase of cardiac cycle. It is measured by equals diastolic pressure plus 1/3 rod of pulse pressure. Stages of septic shock A. Hyperdynamic, warm, shock. 107. This stage is reversible stage. Patient is still having inflammatory response and so presents with fever, tachycardia, and tachypnea. Pyrogenic response is still intact. Patient should be treated properly at this stage. Based on blood culture, urine culture, depending on the focus of infection, higher antibiotics like third-generation cephalosporins, aminoglycosides, metronidazole are started. The underlying cause is treated like draining the pus, laparotomy for peritonitis, etc. Ventilatory support with ICU monitoring may prevent the patient going for the next cold stage of sepsis. B. Hyperdynamic hypovolemic septic shock, cold septic shock, here pyrogenic response is lost. Patient is in decompensated shock. It is an irreversible stage along with MODS, multi-organ dysfunction syndrome, with anuria, respiratory failure, cyanosis, jaundice, liver failure, cardiac depression, pulmonary edema, hypoxia, drowsiness, eventually coma and death occurs, irreversible stage. Treatment of septic shock: correction of fluid and electrolyte by crystalloids, blood transfusion. Perfusion is very, most important. Appropriate antibiotics, third-generation cephalosporins, aminoglycosides. Treat the cause of focus, drainage of an abscess, laparotomy for peritonitis, resection of gangrenous bowel, wound excision. Pus, urine, discharge, bile, blood culture and sensitivity for antibiotics. Critical care, oxygen, ventilator support, dobutamine, dopamine, noradrenaline to maintain blood pressure and urine output. Activated C protein prevents the release of inflammatory mediators and blocks the effects of these mediators on cellular function. Monitoring the patient by pulse oximetry, cardiac status, urine output, arterial blood gas analysis. Short-term, 1 or 2 doses, high-dose steroid therapy to control and protect cells from effects of endotoxemia. It improves cardiac, renal and lung functions. Single dose of methylprednisolone or dexamethasone, which often may be repeated again after 4 hours, is said to be effective in endotoxic shock. B. Septic shock. XX common causes are biliary, urinary, GIT sepsis, peritonitis, strangulation, respiratory, pneumonia. XX common bacteria are E. coli, Klebsiella, Pseudomonas. XX common pathophysiologies are release of toxins, neutrophil activation, cytokine release, and sick cell syndrome, SIRS, MODS. XX clinical stages are hyperdynamic AMD. Hyperdynamic XX find out the source of the infection by US, CT scan. XX do pus, blood, urine culture. XX start antibiotics of high generations like ceftazidime, amikacin, sfoperazine. XX dopamine, dobutamine infusion, slow. XX monitoring by pulse, BP, respiration, urine output, level of consciousness. XX ventilator support, ICU management. XX treat the causes like peritonitis, abscess. Seven. Anaphylactic shock injections, penicillins, anesthetics, stings, venom. Shellfish may be having antigens which will combine with IgA of mast cells and basophils, releasing histamine and large amount of SRSA, slow-releasing substance of anaphylaxis. They cause bronchospasm, laryngeal edema, respiratory distress, hypotension and shock. Mortality is 10%. Rashes all over the body are commonly observed. B. Anaphylactic shock. XX sudden onset. Distributive shock. XX bronchospasm. Laryngeal edema. XX generalized rashes and edema. XX hypotension. Feeble pulse. Mortality 10%. XX to start adrenaline 100 UGIV. Steroids. IV fluids. Oxygen with foot end elevation. Ventilator in severe cases. XX cardiac massage. Defibrillation. Clinical features of shock. Hypovolemic shock in early stage, tachycardia, sweating, cold periphery, hypotension, restlessness, air hunger, tachypnea, oliguria, collapsed veins. In late stage, cyanosis, anuria, jaundice, drowsiness. Clinically, shock may be compensated with mild tachycardia, normal blood pressure, urine output, normal respiration and mild lactic acidosis. Mild shock with mild lactic acidosis, tachycardia, tachypnea and anxiousness. Moderate shock with significant lactic acidosis, decreased urine, tachycardia, tachypnea, drowsiness, and mild hypotension. Severe shock with severe lactic acidosis, anuria, tachypnea with gasping, severe tachycardia, profound hypotension and unconsciousness. Note: shock index is ratio of pulse rate to blood pressure. Normal shock index is less than 1. In shock it reverses. Tachycardia, tachypnea, oliguria, hypotension are typical features in shock. B. Complications of shock. XX acute respiratory distress syndrome and respiratory failure. XX acute renal failure, hypoxia, metabolic acidosis, stress ulcers, ileus, liver failure. XX disseminated intravascular coagulation, DIC, and thrombocytopenia. XX systemic inflammatory response syndrome and multi-organ dysfunction syndrome, MODS. Assessment, investigations and monitoring. Regular monitoring of blood pressure, pulse, heart rate, respiratory rate, urine output measurement, hourly, should be done. Urine output should be more than 0.5 ml per kilogram per hour. Pulse oximetry should be used. Central venous pressure, CVP, only have gross assessment, pulmonary capillary wedge pressure, PCWP, an accurate assessment of left ventricular function, monitoring should be done. ICU care is needed during monitor period. But both CVP and PCWP are not accurate method of assessing tissue perfusion. Complete blood count, ESR, pH assessment, serum electrolyte estimation, chest X-ray, to rule out ARDS, pulmonary problems. Pus, urine, blood, bile, sputum cultures depending on the focus and need in sepsis. Serum lactate estimation is an important prognostic factor. Level greater than 2 mEq/L suggests tissue ischemia. USG of part, CT, MRI of the location of the pathology of the septic focus should be done, often may require repetition of these imaging to assess progress. Blood urea, serum creatinine, liver function tests, prothrombin time, PT, activated partial thromboplastin time, UP, ECG monitoring also should be done. All these tests including platelet count and arterial blood gas analysis, ABG, should be repeated at regular intervals. Treatment of shock. B. Guidelines to treat the cause, to improve cardiac function and to improve tissue perfusion. B. Treatment of shock. XX first stabilize the patient with initial resuscitation. XX next evaluate the patient for cause and severity. XX lastly treat the specific cause to achieve cure. Initial acute critical care management using A. Airway, B. Bleeding, C. Circulation, D. Disability. Drugs. A. Exposure is primary assessment and resuscitation should be done. 109. Treat the cause, e.g. arrest hemorrhage, drain pus. Fluid replacement, 3/4. Plasma, normal saline, Ringer's lactate, plasma expander, Hemixel, maximum 1 liter can be given in 24 hours. 3/4. Initially crystalloids then colloids are given. Blood transfusion is done whenever required. Fluid therapy is ideally done with crystalloids like normal saline, Ringer's lactate, Hartmann's solution. Blood loss should be corrected by blood transfusion only. Crystalloids and colloids do not have O2 carrying capacity. Hypertonic solutions like dextrose are poor volume expanders and so should not be used in shock. 3/4. Dynamic fluid response is studied by using 500 ml of warm normal saline, or RL, in 10 minutes using 2 wide-bore IV cannulas. Responders show improvement. Transient responders show improvement temporarily but revert back to original status probably due to still existing fluid, blood loss or still existing fluid shift from intravascular space. Non-responders will not respond as fluid loss is severe and persistently ongoing. Fluid therapy is continued as 20 ml per kilogram or 150 ml per hour with adequate monitoring, urine, CVP, MAP. Inotropic agents, dopamine, dobutamine, adrenaline infusions, mainly in distributive shock like septic shock. B note, XX dopamine improves renal and splanchnic blood. XX dobutamine improves the cardiac output. XX adrenaline, levateranol IV in anaphylaxis. XX amrinone and milrinone are newer inotropic drugs. Correction of acid-base balance. Acidosis is corrected by using 8.4% sodium bicarbonate intravenously. Steroid is often life-saving. 500-1000 mg of hydrocortisone can be given. It improves the perfusion, reduces the capillary leakage and systemic inflammatory effects. Antibiotics in patients with sepsis, proper control of blood sugar and ketosis in diabetic patients. Catheterization to measure urine output, 30 to 50 ml per hour or greater than 0.5 ml per kilogram per hour should be maintained. Nasal oxygen to improve oxygenation or ventilator support with intensive care unit monitoring has to be done. CVP line to perfuse adequately and to monitor fluid balance. TPN is given when required. PCWP to monitor very critical patient. Hemodialysis may be necessary when kidneys are not functioning. Control pain using morphine, 4 mg IV. Ventilator and ICU, critical care management. Injection ranitidine IV or omeprazole IV or pantoprazole IV. MAST, military anti-shock trouser, provides circumferential external pressure of 40 mm of mercury. It is wrapped around lower limbs and abdomen, and inflated with required pressure. It redistributes the existing blood and fluid towards center. It should be deflated carefully and gradually. Note, activated C protein which prevents the release and action of inflammatory mediators once used is said to be not beneficial now. The patient is monitored with ECG, pulse oximetry, blood pressure, invasive blood pressure, CVP, PCWP, urine output, pupillary reaction, dilated or not, serum electrolytes, arterial PO2 and PCO2 analysis. Central venous pressure, CVP. It is a method to measure the right atrial pressure by placing a venous catheter, 20 cm, into the SVC, superior vena cava. Commonly for CVP monitoring, a venous catheter is passed through internal jugular vein or infraclavicular subclavian vein to the SVC, used for TPN purpose. Occasionally a long catheter, 60 cm, can be passed through basilic vein, not commonly done. Under radiological guidance, initially a needle is passed 3 cm above the medial end of the clavicle, in the hollow between the two heads of sternomastoid muscles, directing towards the suprasternal notch into the right internal jugular vein. Then through a guide wire, a venous catheter is passed into the SVC through right internal jugular vein, which can also be confirmed by changes in flow during inspiration and expiration. Catheter is connected to saline manometer, taking manubriostenal angle of Louis, as 0. B. Central venous pressure XX normal value is 2-10 cm of saline XX if less than 2 cm, more fluid is infused XX if more than 10 cm. Fluid infusion should be restricted. Note, it may be useful to assess the preload and response to fluid therapy. Even though it is not ideal, it is commonly used in ICU as it is technically simpler. Complications of CVP: pneumothorax, hemothorax, injury to brachial plexus and vessels, bleeding, sepsis, catheter displacement. Central venous pressure, CVP, cannula. Note the location of tip of CVP line in the SVC, or can be in the right atrium. CVP line for monitoring and perfusing the patient in shock. Pulmonary capillary wedge pressure, PCWP. It is a better indicator of circulating blood volume in left ventricular function. Catheter used as Swan-Ganz triple-channel pulmonary artery balloon catheter. B. It is used to XX differentiate right and left ventricular failure, pulmonary embolus, septic shock. XX to measure and monitor cardiac output during the use of inotropic agents, vasodilators and fluid therapy. Pulmonary capillary wedge pressure. Note the wedged balloon in the tip of the venous catheter in the pulmonary arteriole. Differences between CVP and PCWP. CVP. PCWP. Technically easier. Requires skilled experts. Normal pressure is 2-10 cm of saline. 8 to 12 mmHg. Gives gross idea about fluid balance. Better and specific. Left ventricular function is not assessed. Left ventricular function is very well assessed. Not used to differentiate between right and left ventricular function. Very well differentiated. Can be kept in situ as long as desired. Cannot be kept in situ for more than 72 hours. Catheter tip is in SVC. Catheter tip is in pulmonary capillary with wedging. Plain tip catheter. 1.5 ml air-filled balloon tip. Can be used for TPN, fluid infusion, etc. Cannot be used for TPN or fluid infusion. Complications are easy to tackle. Often difficult to tackle. Not as sensitive and specific as PCWP. Sensitive and specific. Under strict aseptic precaution, using cannula and guide wire, catheter is passed through internal jugular vein into the right atrium. Balloon is inflated by 1.5 milliliters of air and then negotiated into pulmonary artery until it reaches a small branch and wedges it. Pressure at this point is called as pulmonary capillary wedge pressure. PCWP normally is 8 to 12 mmHg, considering mid-axillary point is 0 reference point. After that, balloon is deflated to get pulmonary artery pressure, which is normally 25 mm of mercury systolic and 10 mm of mercury diastolic. PCWP catheter can be kept in situ only for 72 hours. Complications: arrhythmias, pulmonary artery rupture, balloon rupture, pulmonary infarction, pneumothorax, hemothorax, bleeding, sepsis, thrombosis. Systemic inflammatory response syndrome, SIRS. SIRS is systemic manifestations of inflammation due to variety of causes like infection, pancreatitis, polytrauma, burns, transfusion reaction, and malignancy. So it is often categorized as infectious cause SIRS or non-infectious cause SIRS. It causes either hypothermia, greater than 38 degrees Celsius, or hypothermia, less than 36 degrees Celsius, tachycardia, pulse greater than 9O per minute, tachypnea, greater than 2O per minute, total white cell count greater than 12,000 qmm, or count less than 4,000 qmm. It is final common pathway in shock due to any cause, trauma, sepsis, endotoxemia, burns, where there is failure of inflammatory localization with vasodilatation, increased endothelial permeability with damage, thrombosis, leukocyte migration and activation. It is associated with release of free radicals, abnormal arachidonic acid release, cytokine release, neutrophil sequestration, abnormal no synthesis, complement activation, DIC. It is a part of severely decompensated reversible shock which eventually leads to MODS, multi-organ dysfunction syndrome, a state of irreversible shock wherein patient is anuric, drowsy, cold and terminally ill. SIRS carries poor prognosis. Multiple organ dysfunction syndrome, MODS. It is progressively becoming irreversible injury of all tissues like kidney, lungs, liver, GIT. Lungs and liver are commonly involved, 70%. Next organs to be involved are kidney and GIT. Order of involvement of organs in MODS is: lungs right pointing arrow right ventricular failure right pointing arrow liver right pointing arrow kidney. But mortality is higher if kidney and lungs are involved. It occurs in critically ill patient after severe trauma, burns, acute pancreatitis, bleeding and sepsis. It is more common in elderly, diabetic, smokers, alcoholics, cirrhosis, malnutrition, patients under steroids and cytotoxic drugs, and uremia. Multiple features related to multiple organ dysfunctions are typical. Oliguria, jaundice, hypotension, drowsiness, respiratory distress are common. Platelet microaggregation, acute pulmonary hypertension, ARDS, DIC, circulatory failure with reduced total oxygen utilization in spite of adequate oxygen supply, impaired defense mechanism are the pathogenetic features. Respiratory, renal, hepatic, circulatory, coagulative and cardiac failure occurs as an end-stage MODS. Primary MODS is due to a well-defined cause like pulmonary contusion, rhabdomyolysis, multiple transfusions. Secondary MODS occurs as a result of host response in SIRS. Management of MODS is critical care in ICU with ventilator support, hemodialysis, transfusions, antibiotics, proper nutrition in the form of TPN or enteral. MODS stage has got high mortality. Oxygen therapy indications: 1. Chest injuries, any severe hemorrhage. 2. Gas gangrene with toxic hemolysis. 3. Coal gas poisoning. 4. Over-morphinization. 5. Pulmonary embolism and fat embolism. 6. Spontaneous pneumothorax, pulmonary edema, cardiac infarction, pneumonia, copulmonale. 7. Cardiogenic shock and acute bronchitis. 27% oxygen is delivered through venti-mask disposable polythene mask at a rate of 4 to 6 liters per minute. Oxygen is also given along with positive pressure ventilation. Hyperbaric oxygen. It is administration of oxygen 1 or 2 atmospheres above the atmospheric pressure in a compression chamber. It increases the arterial oxygen saturation so that oxygen perfusion of tissues will be increased. Indications: 3/4 carbon monoxide poisoning, tetanus, gas gangrene infections. 3/4 bed sores, frostbites, necrotizing fasciitis. Drenching in paralytic ileus to reduce the nitrogen gas in distended bowel. As a radiosensitizer in the treatment of cancer. Complications: cerebral gas embolism, rupture of tympanic membrane, visual defects, O2 toxicity, CO2 narcosis, respiratory depression. Contraindications: asthma, emphysema, high fever, chronic sinusitis, viral infection, pregnancy. Cardiac arrest: it is the cessation of the heart. Heart stops contracting. Causes: all causes for shock. B. Features of cardiac arrest: XX no palpable pulse, XX heart sounds not heard, XX cessation of respiration, cyanosis occurs, XX development of unconsciousness, XX pupils start dilating. Critical period: once heart and lungs stop, brain death occurs in 3 minutes. B. Immediate measures: XX airway, XX cardiac compression. Once patient recovers, the cause and sequelae has to be managed properly. B. Sequelae are due to hypoxia and circulatory collapse, XX breathing, XX drugs and defibrillator, XX ECG, endotracheal tube and monitor. A. External cardiac compression, massage, patient is laid flat on a hard surface, never on soft surface. Manual compression is exerted over the lower sternum using both hands one over other without bending the elbow at a rate of 60 to 70 per minute. Rib cage damage during procedure can be very well ignored. Heel of right hand is placed over the sternum 8 cm above xiphoid process and left hand is placed over it. B. Another person at the same time should give mouth-to-mouth breathing at a rate of 20 to 30 per minute after clearing the airway by removing froth and dentures. A bag with mask can be used to ventilate using air or oxygen. C. Endotracheal intubation and ventilator support. D. Injection of 1/10,000 adrenaline and 10% calcium chloride intravenously. A. Sodium bicarbonate 8.4% injection, hydrocortisone injection. F. Defibrillator, if there is ventricular fibrillation. G. Analysis of blood gas, PCO2 and PO2, and serum electrolytes assessment at repeated intervals. H. Urinary catheterization, Riley's tube insertion. I. Monitoring the patient with BP, pulse, respiration, and temperature chart. Observations to be made are: groin pulse, XX respiration and breath sounds. Blood pressure, XX pupillary reaction, XX ECG activity. Sequelae are due to hypoxia and circulatory. Cerebral edema and permanent brain damage, XX adult respiratory distress syndrome, ARDS, XX renal failure. Internal open cardiac massage. This method is used when cardiac arrest occurs in the operation theatre during surgery, acute tamponade, and acute bilateral pneumothorax. Left side thorax is opened through a lengthy incision along 4th or 5th intercostal space. Initially, heart with intact pericardium is rhythmically compressed and relaxed using left hand against sternum. Meanwhile, costal cartilages above and below are cut with a knife to have a better exposure. Pericardium is opened in front of the phrenic nerve. Direct cardiac massage is undertaken until heart regains its function and later shifted to ventilatory support and critical care. Defibrillation technique, cardioversion, apply gently to the site of electrodes. One electrode at the base of heart to the right of the sternum, other over the estimated area of the apex of the heart. Ensure that nobody is in contact with the patient. Activate the defibrillator. Resume ventilation and ECG monitor immediately. After that, monitor continuously, correct the acidosis, catheterize and observe urine output. Arrange for ICU care.